Hi everybody, I'm Dr. Deed Harrison. We're here to go through this week's CBP nonprofit research video review. It is May 18th, Wednesday today, 2016. We're going to go through one of my personal favorite papers and my personal favorite topics. It's about anterior head translation or vertical head translations, a straightening of the cervical curve from the side, and how that affects osteoarthritis, or what we call spinal arthritis and disc disease. So we're going to go through this paper. It is entitled Evaluation of Axial and Flexural Stresses in the Vertebral Body, Cortex, and Trabecular Bone in Lordosis and two Sagittal Cervical Translation Configurations with an Elliptical Shell Model. By myself, lead author, William Jones, PhD, engineer, from Mississippi State, Professor Tadeusz Janek, formerly at University of Alabama, Huntsville, and my late father, Dr. Don Harrison. This particular paper is a spine model of the sagittal plane configuration. Now, last week, video 31, we went through the same model, but we applied that to cervical kyphotic configurations or reversed cervical curves. This time we're going through what we call translation configurations in the sagittal plane. This was published in JMPT 2002, volume 26, page 391 through 401. Now to begin, normal head posture is defined in the sagittal plane as vertical alignment of the center of gravity or center of mass of the skull relative to the center of mass of the upper torso. Now classically what we do is we identify the center of the glenohumeral joint or the shoulder joint. We put a dot there, and the external auditory meatus, the EAM, should approximately line up with that point. Now, that's an average estimate of the approximation alignment of the centers of mass. Truly, the center of mass of the skull sits just superior and anterior to that EAM point. Okay? One thing we do have to be cognizant of when we're using external measurements like shown here is the position of the shoulder girdle from the side. Now obviously the shoulder can roll forward and backwards. It can do what's called protraction and retraction, or internal and external rotation of the glenohumeral joint. So we have to account for that in external measurements as well. However, it can be quite obvious when you see a patient from the side that they have what we call anterior head translation. Now shown in this example is a patient case that has anterior head translation. So the anterior head translation is where the EAM is in front of the shoulder, and the shoulder is relatively aligned, but you can see a little bit of protraction and internal rotation of the scapula and glenohumeral joint. What that really means is the head is likely further forward than it appears in this photo. There's also a head tilt or a slight head flexion. Now the reality of it is this is forward head translation. This is one of the things we're going to be discussing in this paper. Now, forward head translation, although common, it is not good for you. It causes a myriad of health disorders, or it correlates to a myriad of health disorders. Now, always in the literature, there's hit and miss studies. You can argue back and forth, but I'm here to tell you my position is the majority and the best quality studies show that this particular posture is abnormal for the human spine. It will cause or be associated with increased rates of certain conditions, and we're going to talk about one, namely increased or accelerated rates of spinal arthritis and disc degeneration. Now, looking at the neck curve from the side, I feel, and most doctors feel, this is more accurate. The posture externally shows us the external idea that there's forward head translation, but we truly don't know what we're going to see on a spine x-ray. So shown on the reading left is a normal configuration for the cervical curve from the side. This would be somebody that does not have forward head translation. The top of the neck lines up with the bottom of the neck, and you can see that. And there's a proper cervical curvature in there where we have a uniform rate of curve where each disc space in the neck contributes about an equal amount or an approximate equal amount to the total curve. Shown on the reading right is a patient case that has conditions like neck pain, headaches, in this case heart palpitations, shortness of breath, not a cardiac dysfunction, a cervical problem mimicking cardiac dysfunctions. Okay, now this person, you can see, has significant anterior head translation, okay, where the top of the neck is in front of the bottom of the neck or the upper thoracic spine. Their curvature is altered, and they have degenerative disc disease and bone spurring osteoarthritis in this region in their neck. Why is it there? That's one of the things we're investigating in this particular project. It's actually the primary thing. Do translations forward or straight up and down with a straightening of the cervical curve, do they increase the stresses, force per unit area, acting on the spine tissues enough to accentuate or cause spinal arthritis and disc disease, also known as osteoarthritis, bone spurs, etc. Now, I want to go through some simple physics with you. We know this, the weight of the human skull in a given patient at a given time doesn't change. Okay, weight is mass times gravity. Okay, so mass times gravity, that's the weight. Okay, force is mass times acceleration. So the force of the head acting on the neck is not going to change. It's the mass of the skull multiplied times gravitational acceleration. We know that that's constant. However, when you change the posture, by moving it forward, you are changing the mechanical advantage of the system. You're changing the lever arm. You're actually increasing the lever arm where the load acting down due to the weight of the skull is now going to increase loading via what's called increase in the torque vector. Now I want to show you a couple simple examples on the screen, and then I'll show you the complexity of it when we're getting into the spine. Now everybody knows that if you've got a bolt that's frozen or it's rusted on, you don't want a little bitty wrench, you want a long wrench. And if I have a long wrench and I push down at the end of the handle of the wrench, I have a really long lever arm, and that's going to increase the effective load that is experienced at the axis of rotation, which is my bolt and my hex nut here. Now the reality of it is that creates what's called a torque vector. The torque vector is the effective force. Okay, in our situation we're talking about the force of the skull, which is mass times acceleration, multiplied by the lever arm. So the torque vector is, in this particular case, 24 Newton meters. Newtons is the force, 0.2 meters is 20 centimeters. So then you multiply the two together and you have the units of measurements together, so it's 24 Newton meters. Now if I increase the length of my lever arm, I obviously increase the effective torque vector. What's going to happen is the load and the lever arm makes a plane. So if I look at the lever arm and the load, I have a two-dimensional plane. The torque vector is going to be perpendicular to that plane, and it's going to create a twisting or a turning about that axis, right? This is the simple physics of it. So by increasing the lever arm, I increase the effective load experienced at the axis of rotation, and it's really a torque vector. Okay, now in the spine, we're going to refer to this as moment arms. Okay, so the reality of a force system in the spine, it gets quite complicated because it's not just a simple lever arm change. Muscles change their line of action as your posture moves in different directions. So what we get here is a relative complex force system, but we can break it down into simple physics. Okay, so shown in this diagram is what's called FM, the force of muscle action. Okay, so the force of muscle action here is FM. Fy is the rotatory force or torque vector. Now this would be what the upper thoracic spine and lower neck is going to have to resist. It's going to have a torque vector moment arm on it. So a rotatory torque or a rotatory torque vector. Okay, so Fy is showing this particular concept. Fx is the compression load experienced at the joint. Now here it's saying that this creates joint stability. Well, yes, compression loads on the spine do stiffen and create stability, but that compression load can also increase at a rate that's too large, and it can create complex problems, okay? So Fx is my compression load. And then Fg is the gravitational force, or what's called the weight arm, and that's acting straight down. The theta here is the angle of muscle insertion, and then the mechanical advantage of the system would be Fm divided by Fg, so Fm divided by Fg. And what we have to remember here is the moment arm is always perpendicular to the muscle force line of action. Okay, so this is the reality when we talk about the cervical joint or a cervical joint, what it's going to experience in terms of its overall what we call free body diagram. Okay. Now, when we look at the spine in the sagittal plane, we can apply this information simple physics-wise, and we can see that people that change their sagittal configuration, they're at risk of problems. For example, this particular project came out in 2002 in the Journal of Neurosurgery by Mayman et al. And what they did is they simply took cadavers, and in this case we're removing the muscle loads. We just have, the weight of the system itself with a wet specimen. It's got, some ligaments, discs, the bone, the skull, etc. But it's not a live person, so we don't have actual muscle loads. And what they did is they configured the neutral position of the cadaver in 3 different scenarios. Number 1, the head forward. We call that positive TZH, or simply anterior head translation. Okay, forward head shift. Then we have a neutral configuration, and then we have a translation of the spine posterior called negative TZH. Now in this neutral, they're actually calling neutral vertical alignment. Neutral in the cervical spine from the side would actually be a nice cervical curve. In this case, they've removed that just to remove one of the variables, okay? So keep in mind, true neutral is a lordotic neck. This one is a pure military or straight up and down. We call it military posture, okay? So basically what happens is when you apply load to the system, anytime there's translation forward or backwards, you're changing the lever arm. So I get a force multiplied times its lever arm. That's going to create what's called eccentric loading or non-centered loading. Now we're going to see certain tissues are at greater risk of injury. In this case, they identified spine fracture will occur in the lower segments at the anterior 1/3 of the specimen due to this offset being translated forward. So if your head posture's forward and you get in a compression load, let's say something falls on you, you're a material handler and you've got a hard hat on. Thank God you got the hard hat on, but something falls on you and your head's forward due to that load being shifted forward of the skull, and then now that force coming down multiplied times the acceleration of gravity, that hits you, that's going to cause some type of injury in your spine that may not have occurred had, sorry about that pop-up, had you not had that particular posture. So if you just look at this, they said, you know what? Head and neck specimens were placed into positive eccentricity. That means anterior skull to the upper thoracic spine. What happens is you'll get different types of injuries, including wedge fractures, ligamentous injuries, burst fractures, and or linear vertebral body fractures. Okay, so the further the eccentricity or the non-centered position of the spine, the greater the probability of having these types of injuries. Okay, so we know anterior head translation carries with it a risk of injury. So some people go, oh, well, no big deal, I feel great. Well, hey, you might feel great, but what if you get in an accident or an injury? Do you want to have something that increases the risk of fracture of your neck? I don't think so. So I always look at this and I go, you know what? The patient's pain, having it or not, doesn't really, come into play of whether or not I'm going to teach somebody that this is a problem. They need to understand, just because they feel good does not mean that this posture is good for them. Everybody's going to get in some type of injurious situation. You're going to slip, you're going to fall, you're getting a car accident, whatever it is. You want to make sure that you have the best ability to protect yourself from a greater risk of injury. Controlling your posture in the sagittal plane is one of these mechanisms. Okay. Now, this paper came out later, but I'm going to share it with you because it got a lot of attention. This came out in 2014 at the end of the year. This was done by Hans Raj out of Surgical Technology International. Now, everybody that I know in the healthcare literature kind of jumped on the bandwagon with this paper. But I read the paper, and no disrespect to the author, but it leaves a lot to be lacking. There's actually no equations in there. We don't even know how he modeled the cervical spine. It's such a brief report. I'm here to tell you I don't even think you could reproduce the results of it. The paper that I'm going to show you came out more than a decade earlier that we did, and it's much more sophisticated, and it should have gotten the same attention. Probably the reason it didn't get the same attention is due to what's called now text neck position, right? Like all the adults and the young kids are bending their head forward, they're shifting it forward while they're texting. So the public perception is this is now a greater concern for us. So when this paper came out, it's a simple model of the spine in the sagittal plane, and the author said, look, when your head is not tilted forward into flexion or shifted offset in its eccentricity relative to the upper thoracic spine, the average skull weighs 10 to 12 pounds. Okay? Now, number one, that's not true. Number one, the average skull does not weigh 10 to 12 pounds. It depends on the body mass of the person. This human skull is 7.55% body mass. You can look it up, Clauser et al. In the Air Force in the 1960s and 70s. So number one, that is so simple, you cannot apply that to an individual person. If you're a 200-pound male, your head does not weigh 10 to 12 pounds. So this model is not actually accurate. It's just such a simple guesstimate, it's actually incorrect, but the public jumps on board with it. So 10 to 12 pounds, this is the weight of your skull in the neutral position. Force applied to the cervical thoracic spine. You tilt your head 15 degrees forward, the effective load of your head becomes 27 pounds. Okay, now realize your head's weight is not changing. However, the force or the effective load applied to the cervical spine has more than doubled with a 15-degree offset. Okay, and that's due to the lever arm change, so I'm increasing the torque vector. Okay, so we went through that. It's applying simple lever arms to the equation. Force times lever arm gives me the increased load experience at the axis of rotation in, this would be degree, pounds, right? 15 degree pounds. So we'd be talking about, the effective load is 27 degree pounds, right? It would be how we would list that. And at 30 degrees forward, the author estimated the effective load on the neck at 40 degree pounds, right? And then at 45 degrees, it's 49 degree pounds. And then at 60 at 60 degrees, it's 60 degree pounds. Now, the reality of it is very simple, not necessarily a validated model. However, you get the idea that due to the offset of the skull center of gravity in the sagittal plane, it's increasing the effective load that's experienced by the cervical spine. Okay, so the author's conclusion is an adult head weighs 10 to 12 pounds in the neutral position. As the head tilts forward, the forces acting on the neck surge to 27 to 60 pounds. Okay? Simple model. Well, what's that going to do? Well, we're going to look at, is that load enough to trigger what's called osteoarthritis development or degenerative disc disease? Is that going to accentuate or accelerate the rate of deterioration of my spine tissue? Okay, so just to show you, here's an x-ray that shows pretty bad damage to these discs here. And then when we look on it, or look at that same neck on an MRI, you can see these little fingers sticking out here, bone spurs and disc herniations, and that starts to put pressure on the spinal cord. So osteoarthritis and disc disease is not good for you. It's not normal for you. Although it occurs naturally as you age, it is not good for you to experience this at accelerated rates. Because when it gets out of hand, it starts to put pressure and put loads acting on your nervous system. Your nervous system doesn't like increased loads on it. Ask anybody with this type of neck, they're not doing so well. They have some kind of health condition going on, whether it's numbness, tingling, pain, weakness, or other more serious conditions. Okay, so last week we reviewed the causes of spinal arthritis and disc disease, and just, to reiterate, trauma, poor diet, lack of proper movement and exercise, genetics play a role, and then spine alignment, altered gravitational loads, play alignment in accelerating the rates and development of spinal arthritis and disc disease. Okay? Since bone remodels to the stress placed on it via what's called Wolff's Law stress-generated potentials, an evaluation of the actual loads and stresses, and this should say in translation cervical configurations would be of interest. I accidentally patched in last week's slide here. That should say translations. We'll talk to you about what we did. We hypothesized that increased stress, force per unit area, at the anterior and posterior vertebral bodies would occur in these translated configurations compared to a neutral lordotic specimen. So here's what we did in this particular study, and you can see now I'm fraught with typos. Forgive me if you're watching this. Excuse that I patched in and forgot to change. This time we took 3 lateral cervical radiographs of subjects taken in the standing neutral position. We took a lordotic configuration, that's here in the middle, where the top of the neck is lined up with the bottom of the neck or the upper thoracic spine. So there's no offset, there's no lever arm or what's called eccentric loading. Here we chose a true translation in the sagittal plane anteriorly. So we've got E being my lever arm here, my eccentric shift forward, right? And so you can see that lever arm from C1, where the effective weight of the head acts at the lateral mass, you can see E is the lever arm that is experienced at T1 vertebral body center, okay? And then L7 is the lever arm of C7 vertebral body center. And as you move forward, or upward, superiorly, the lever arms are getting smaller. Okay, that's because the actual load of the skull acts through C1 lateral mass. Okay, and then we have the actual center of gravity of the skull, which is depicted here, and we have a lever arm here that's the anterior lever arm from the center of gravity of the skull to the atlas lateral mass. So we chose 3 configurations to study: anterior translation, neutral with a lordosis, and then a pure vertical translation where there's no forward and backwards offset, but we've altered the cervical curvature, changing the effective load acting on each part of the vertebral body. Your cervical spine is supposed to be a tripod. The front of the vertebra here is the vertebral body. That's the front leg of the tripod. Okay, so that would be my middle finger here. That's the vertebral body. Well, in the back, I have 2 legs of my tripod. Those are called the articular pillars. They're sitting right here. I'll show that in another picture. Well, when you straighten out the neck curve, you're changing weight from the back 2 legs of the tripod to the front only. So there is going to be an increase in load experienced by this particular displacement of the spine, certainly in the mid and lower cervical spine. Okay, so we used our past model that we went through, and I've briefly explained this already. I don't want to dive in too much detail into the model again. You can look at last week's presentation for a more detailed review, or you can read this particular paper. And you can see what I did again is I just left the reversed configurations in here instead of the actual 3 configurations that we're studying in this project. We used the same type of elliptical shell model where we broke down cortical bone versus medullary bone of each vertebra. And the equations and the rationale for doing that was explained previously, and it's also in the particular project. Here you can see my tripod that I was referring to. This is a bird's eye view. Let's say this is cervical vertebra number 5. Here's the vertebral body. There's the center of it. This is my front leg of my tripod. This is the back left leg. That's the back right leg. Now, bird's eye view, when we look at it from the side, here's the front leg, and here's the back 2 legs superimposed on each other. We know that the cervical vertebra act as a tripod such that the back 2 legs bear anywhere from 60 to 68% of the total effective compression load. So when you straighten out your neck curve, you're going to alter that load sharing scenario. Okay? Again, here's the 5 equations that we used. to calculate the anterior and posterior vertebral body stresses and the medullary versus cortical bone loads. And again, I'm not going to go through this. I did this last week. Either watch last week's video presentation or you can read this particular paper. I just kind of want to skip through this and get to the more clinically relevant findings of the particular project. Okay, so here's what we identified. We identified that our elliptical shell model was able to actually separate stresses into the cortical part of the bone, which is the outer part of the vertebral body, the hard cortical shell of the bone, versus the internal spongy bone, what we call medullary bone. The axial or compression, and then flexural. Flexural is the bending moment loads that are experienced at the tissue. So this would be, more like the loads experienced from the torque vector. This would be axial load is not only the weight of the skull, but also when your head goes forward, it's increasing the effective load because the muscles have to contract to resist that. So I get a net compression load that's acting down. So that's my axial component of the load. So axial is compression. This is more of what we call the bending moments. These were approximated by use of a short compression block model and short compression block equations that we applied to the cervical spine. Of interest, they fit the criteria for the use of what's called short compression block equations. They are validated in this scenario, and you can look that up in this particular project and see our justification or rationale for that. Okay, so we studied these three configurations. The combined stress directions changed in the lower cervical segments compared to normal in the two translated postures. So number one, the force per unit area changed directions when I translated my head forward or I lost my cervical curve compared to neutral, such that instead of a tensile load mildly experienced at the front of the vertebral body, there is now a large compression load. Also, not only did the stresses change directions, their load magnitude increased, such that the lower cervical segments, depending on if you were anteriorly translated or vertically translated, the magnitude of the stresses increased by a factor of 1.25 up to 4.25 times what the normal configuration was under or experienced or predicted by the model, okay? So basically, a factor of 1 to 4 times greater magnitudes of load experienced in my lower cervical spine tissues. We suggested that this has implication for bone remodeling, which is bone spurring, osteoarthritis, disc degeneration, etc. So here's a graph of what we're getting at with this description in the results. This is the graph of the distribution of the anterior stresses in the anterior cortex. Now, 0 means no load, compression, or tension. That's my neutral axis. The stress here is in pascals, okay? Now, if I'm negative, if I'm below, it should be negative, but we listed it as positive. Below is tension, and above is compression. Okay, so I look at first the normal lordosis in the diamond. Here's C2 segment, here's C3, here's C4, 5, 6, 7, and T1. Now, you'll notice that T1 is almost experiencing 0 tensile load, okay, in the anterior cortex. That's because this is the fixed point, and this is where we don't have a big lever arm offset, okay? Now here, we're experiencing a greater amount of tensile load because there is an offset, a lever arm from the neutral axis towards the vertebral body location when I have a lordosis. It's further away from what's called the overall net compression load acting on the spine, okay? So T1 has less tensile load at the anterior cortical margin, and then the greatest would be at C5, followed by C4 and C6. Okay, so in all, it's actually a mild tensile load that the anterior cortex or the anterior disc fibers or the anterior longitudinal ligament would be under, right? Now, if you start to look at a straight neck, the vertical one, no neck curve, so purely straight up and down, that's this one right here. All of a sudden, you'll see it's about the same at C2 and C3, but whoops, it changes direction from tension at C4, and now it's under compression compared to the normal. And then it becomes peaked at 5 and 7. Okay, so 5 and 7, and then, you would say approximately C5 through T1 are experiencing the same magnitude of load in Pascal. It's relatively high compression load, okay? It should be under a mild tension. Okay, now, if I jump to the anterior translation, forward shift, this one should theoretically create larger net reaction load due to the increase in the torque vector and due to the increase in the compression loads created by the muscle activity required to stabilize this and counteract the torque vector. Okay, so I look at this and I go anterior translation lordosis forward. Right here at C4, it starts to approach the neutral axis. At C5, it's changed directions. It's still less than what my straight neck is, but right here, wow, the load really starts to increase. So right here at C6, C7, and T1, this is the area that's experiencing a really significant compression load. It's roughly 4 to 4.2 times higher than the overall absolute value that should be experienced in a normal neck curve, and keep in mind it's switched directions. So now your effective load on the neck is much higher, and it's in the wrong direction. Okay? So this translation forward cannot be good for you. Here's the distribution of the stresses in the posterior aspect of the vertebral body. Now, because we've moved from the front of the bone to the back of the bone, the actual direction of the load should change, and that's what we see. The cervical lordosis configuration, again, a really uniform compression load at the posterior body. Okay? Really uniform compression load. However, when we start to look at these two vertical translations, you'll start to see, wow, the load changes direction and it's increased dramatically in magnitude, such that the translation forward is the worst of them, but a straight neck is still not healthy for you either. The loads are anywhere from 1.25 to 4.25 times greater in these configurations compared to the normal lordotic curve. Okay, now, how do we look at this and have application in a clinical scenario? So here's a patient, and we blocked off his face, so for privacy purposes. This person is an older gentleman. He has really large, extreme anterior head translation. This is his neutral position. He thinks he's standing neutral. This is his perception of neutral. Yet the head on X-ray, when we measure it, 103 millimeters forward. Now, to put that in perspective, if you're 5'9", you can only translate a maximum of 3 inches. That's 75 millimeters approximately. This guy is past the allowable range of motion for the average person. In the sagittal plane, his head is way out there, and it's stuck there, and it's deformed there over time. Now, you go, oh, well, that's okay. It's of no consequence to him, right? He's fine. Really? You really think he's fine? Do you think he's going to have much mobility in his neck? Look what's happened. He's been like this for so long. The loads acting on his lower cervical spine are so great, the vertebral body and the discs are starting to deform and deteriorate and degenerate. This is spinal arthritis and disc disease. Look at the spurs here on these vertebrae. Look at here. Why do you see these spurs so large? Well, because instead of a mild tension, like our model predicted, they're under a huge compression load in those lower segments. So you leave that load there over time, and your body does what it has to do to stabilize the region. The load is so great, your body naturally goes, whoa, I better pour more cement there. I got to increase the base, the foundation to support this load. Your body's doing the best it can. Your body doesn't think and go, oh, this is good for me. Your body reacts. Okay? Your body doesn't go, oh, let me change this load. It's stuck there, so your body has to react to it. It has to undergo some kind of an adaptation. If you think that's a healthy adaptation, something's wrong with you. Because I'm here to tell you that this person is not healthy. This person has problems, has consequences. This stuff starts to get so large, it can affect the ability of him to swallow. It will affect his respiration. It will affect many things in the body. right? Now look back here. If you're a doctor, you start to notice this stuff here. You're starting to see calcification of what's called the nuchal line. Okay, these little calcium deposits here means the soft tissue, the ligaments and the muscles back there are under such great tensile load to hold up this system, they're now starting to turn to bone and ossify. That's your soft tissues starting to turn into bone. That's how long this has been there. Okay, this is not a healthy scenario. Anterior head translation, I just want to give you the idea of what this is associated with in the literature. As early as 1993, forward head translation has been found, number one, to be statistically greater in magnitude in people that have pain versus non-pain. For example, this paper, 1993. People with headaches compared to normal subjects, the people with headaches had a greater amount of anterior head translation. However, from a functional point of view, what was found is when your head's forward, your muscle strength and your endurance is reduced compared to when your head is more neutral. That's because you're wearing the system out over time. You hold your head forward, and you try to keep it there, you're changing the lever arm and line of action of the system, and you're making the muscles have to work too hard to create the same type of movement or stability in the spine. Just hold your head forward and try to do strength maneuvers from a forward head position versus keeping your head neutral and doing strength maneuvers. And hands down, you'll find out that there is a relationship between isometric muscle load ability and its endurance. Also, what's been found is, in addition to altering the effective load and strength and what we call how long you can hold that, its endurance, what's been found is it alters your movement, range of motion. Head translation forward has been shown to linearly reduce the amount of available mobility in the cervical spine joints. You translate your head forward 1 inch versus 2 inches versus 3 inches. The person with 3 inches of forward head translation is going to have a statistically greater reduction in the available range of motion compared to the subject that has 2 inches compared to the subject that has 1 inch. Just try it for yourself. Hold your head neutral and then go through some movements and see how you feel. See how it moves. And then translate your head way forward and see how it is. Your mobility, movement is life, and it is directly connected to your posture. This is what this particular study found in 2006. There's a linear correlation between the magnitude of head translation forward and range of motion. Also, there's a correlation between pain and headache frequency, for example, in this case, and how far your head is forward. So it is correlated with some type of dysfunction, but the reality from a biomechanics point of view, it changes the muscle lever arms and it will change the joint reaction load such that you will not have proper mobility in the cervical spine. Have you ever wondered, as you get age, why your mobility changes? Now, some of that is your soft tissue elasticity is changing. However, some of it's because your posture sucks, right? Ask your doctor if your posture sucks, and this doctor's probably going to look at you and say yes, and you probably better do something about it, right? Your posture is linearly related to your ability to move. This one, 2009, Journal of Orthopedic and Sports Physical Therapy, identified the same thing. There is a linear correlation between range of motion and forward head translation. Also, this study identified that carpal tunnel syndrome is related to forward head translation. Your head goes forward, you put stretch, tensile load on what's called the brachial plexus, the nerves that go from your cervical spine through your neck, through the neck muscles down into your arm and hand. People with carpal tunnel feel it here, and you think the only problem is here in the wrist. That's not the only problem. That's one of the problems, but the primary issue might be coming from your cervical spine. You stick your head forward, it's going to create some compression and tension load acting on the brachial plexus. Tension from the stretch, compression from muscle contraction, right? This is what's called a double crush syndrome in the literature. A double crush means I have a pressure up here, a pressure down here. That's two places. I feel the effects in the lower portion what we call distal to the second location of pressure. It's like a hose. You turn on the water. Water's coming out. You step on it in one place, it slightly reduces the flow. But you step on it in another place, it dramatically reduces the flow. Same thing. So if you've got carpal tunnel syndrome, before you start to think about surgery on your wrist, maybe, just maybe, the common sense idea would be, let's check the neck out too before we get a little crazy, right? And I'm not saying that some people don't need that. What I'm saying is, let's also look at the cervical spine. So biomechanically, we see that anterior head translation relates to reduction in movement, relates to reduction in muscle strength and endurance, also relates to different types of pain syndromes. And then the last one, how important is breathing to you? Right? Anterior head translation is critically tied to the ability of your respiratory muscles to function. It will change their line of action, their lever arms, and it will change their maximum output and their endurance over time. This has been investigated. There's several projects on this. This is just one of them. Cephalgia, 2009. 12 patients with chronic neck pain compared to 12 controls, looking at forward head posture and respiratory measurements. Here's what they identified. There's a linear correlation between FHP and reduced respiratory muscle strength. Linear. That means it's not just related. That means for each increment your head goes forward, it incrementally affects the way your respiratory muscles can work and function. So you see somebody that's head's way forward. Just do it. Try to take a deep breath in. See what happens to you. It's much harder. Mechanically, you're making your body work harder to achieve the same thing. Okay? Many studies have been done on this. Right? You see people that are a little bit older. They're hunched forward, their head's forward, and they're on an oxygen, mask, oxygen tank. Well, part of it, maybe they were a smoker and ruined their lungs. But the other part of it is maybe they didn't pay attention to their forward head translation, affecting them over time. And it slowly changes your body's ability and efficiency to respire, right? This is a huge deal. Now, I know I jumped off a tangent here. What I wanted to do is show you, hey, anterior head translation in our paper was related to degenerative changes, right? But some people go, oh, big deal. Who cares if your spine degenerates? You should care. Because that's related to the whole scenario, the cascade of dysfunction that I've gone through here. The whole system is experiencing an increase in mechanical stress and strain leading to dysfunction. We studied the dysfunction in the vertebral body and the disc, and we looked at likely it's going to accelerate and or exacerbate the rate of occurrence of spinal arthritis and disc disease. However, it may actually be more serious than that. If you think about the studies that I went through, these translations in the sagittal plane, losing your neck curve, having forward head translation, it biomechanically changes your body's ability to function under upright gravitational scenarios, right? In conclusion, here's what we identified in this project. Compared with normal lordosis, our present data indicates that translation configurations in the sagittal plane of the cervical spine causes stress concentrations that are 1.25 to 4.2 times higher in magnitude. They also change directions compared to normal. These data suggest that both an anteriorly translated posture and a vertically translated cervical configuration result in abnormal, undesirable configurations of the cervical spine, leading to some type of dysfunction that will likely occur, whether it's spinal arthritis and disc disease like our model would predict, or the other myriad of dysfunctions that I went through at the end. Hopefully you enjoyed this week's CBP nonprofit video research presentation. As always, please consider supporting CBP nonprofit spine research. We are truly a nonprofit research foundation. We have a small budget, but we get a lot done with that budget. What we study is things that affect human health and disease from a spine framework. And when we see patients with these types of spine configurations, there needs to be more research on this. Patients need to be aware of what's happening to them. We don't want to see somebody that walks in when they're 50 years old and says, man, I wish I would have known about this 20 to 30 years earlier. We need to get the word out. We also need your help in investigating spine research projects, and they are dollar and time vampires, if you will. They take money and they take time. Also, if you're a patient out there, please consider finding a CVP trained chiropractor. You can go to cbppatient.com and you can look up CBP trained chiropractors anywhere in the world. They're familiar with this information, and they also know how to actually take this and apply it to you clinically and make sure that they do the best type of corrective care that they can do for you. Until next time, I'm Dr. Deed Harrison.